We're moving on to pre-op preparation and what you as a nurse need to know and what you need to do. The physician is responsible for explaining the surgical procedure to the patient and having the patient sign the consent. The nurse does not ever have the patient sign the consent. It needs to be signed in front of the physician after the physician has told the patient all of the risks and benefits to the surgery. But what does the nurse need to think about? You need to be thinking about assessing and correcting physiological and psychological problems that may increase surgical risk. The nurse must give the patient and the significant others complete learning and teaching guidelines regarding the surgery so that the patient and loved ones can read material, and if they have more questions, then they let the nurse know, and the nurse calls the surgeon to let the surgeon know that the patient has further questions that they need answered. Instructing and demonstrating exercises that will benefit the patient post-operatively. So we want to prepare the patient for what's going to happen after they come out of the surgery. So they're not coming out not knowing what to expect or not knowing what to do. And then, of course, we always are planning for discharge and any projected changes in lifestyle due to the surgery. So just remember, we educate our patients if they're in the hospital a couple days or a day before the surgery. You maybe come in 3 to 5 times and teach the patient on how we're going to help them recover from the surgery. We don't want to give the information all at once, only once, because the patient will probably tune out. You as the nurse, you want to make sure that a health history is obtained and a physical examination is performed during which vital signs are noted and a database is established for future comparisons. So patients have a lot to do before surgery. One includes getting a physical examination. Make sure that the patient has done everything he or she was supposed to do so that the surgery doesn't have to be canceled or rescheduled. What we need to know as the nurse is the age of the patient's usual level of functioning. So are they alert and oriented and ambulatory and can be independent? So if they come out of surgery and that's not the case, then we know that we have a problem. You need to always assess the mouth for dental caries, dentures, and partial plates, because these can be choking hazards during anesthesia. And so before the patient goes down for surgery, you need to take out all of the dentures and partial plates to keep the patient's airway open. You as the nurse want to make sure to assess the nutritional status and needs of the patient. Know that obesity causes risks during anesthesia. Of course, we're going to be looking at labs before we send the patient down for surgery. Fluid and electrolyte imbalance. They could be dehydrated. They could be hypovolemic. And electrolyte balances, make sure the labs are good. And if not, you need to contact the surgeon to see if they want to postpone the surgery or if they give you any orders. We need to know the patient's drug and alcohol use, because this can inhibit anesthesia or actually make it worse for the patient. And anytime we go into surgery, we're concerned about the respiratory status and the cardiac status. We want to keep them breathing and we want to keep their heart pumping. You need to know the medications that can complicate surgery. We're going to talk about that in a little bit. But just know, when you think about a patient going to surgery, Have they done all of their pre-work that they were ordered to do? Have you reviewed that paperwork to make sure everything is within normal limits? If not, you need to call the surgeon to let the surgeon know what's going on. You're always going to assess the patient's mouth before they go down to surgery and take out any partial plates or dentures because we don't want a choking risk. And we need to know their social drinking and or drug use because that can affect anesthesia. And always think we're always worried about breathing and our heart keeps beating. What medications are a red flag for patients going into surgery? We have corticosteroids. We cannot abruptly stop corticosteroids. So this needs to be tapered down before surgery. If we discontinue abruptly, there is risk for cardiovascular collapse. And remember, our responsibility is keep the patient breathing and keep the heart pumping. Diuretics. Thiazide diuretics may cause excessive respiratory depression during anesthesia administration. Antibiotics. The mycin drugs, such as neomycin, and frequently streptomycin, may present problems when combined with a muscle relaxant. As a result, nerve transmission is interrupted and apnea due to respiratory paralysis develops. And insulin. When a diabetic person is undergoing surgery, interaction between anesthesia and insulin must be considered. So how can I remember all of this? Here's a mnemonic I created. Can I do anesthesia? So C is for the corticosteroids. I is for insulin. D is for diuretics. And A is for antibiotics. So always remember this. Can I do anesthesia? Because these are red flags that you need to be aware of and report to the surgeon. As the nurse, you want to ensure that all labs have been completed. Surgical patients will have baseline labs ordered. You need to make sure that they have been drawn and you have results. So you're looking to make sure, are they complete? Are there any labs that are concerning that you need to report to the surgeon? Common labs ordered before surgery include blood analyses such as a CBC, a sedimentation rate, C-reactive protein, serum protein, calcium, alkaline phosphate, and a chemistry profile. But you'll have to look into the patient's medical record to determine what has been ordered. Has it been done? Do you have results? And if anything is out of whack, you need to let the surgeon know ASAP. Here are some labs that you would need to be looking at and looking for. CBC, so an elevated white blood cell count, is indicative of an inflammatory process. So if you have a high white blood count, the surgeon needs to know. A decreased white blood count, or WBC, suggests a viral process might be going on. The surgeon or the attending needs to complete an evaluation because the immune system may be dysfunctional. A low hemoglobin suggests anemia or blood loss. This is going to impair tissue oxygenation and reduces the hemoglobin available to bind with inhalation anesthetics. So they may suggest a need for a cross-match and blood transfusion. So again, something else you need to report to the surgeon. An elevated hematocrit may indicate dehydration, and a decreased hematocrit suggests fluid overload. CDC labs. You need to know the labs and what their normal values should be. So a hemoglobin normal range for males is 13 to 17. For females, it's 11.5 to 15.5. You can maybe remember this because females go through puberty at around 11, earlier than men, and males go through puberty around 13. So that's an easy way to remember. Hematocrit normal range, for males, it's 40 to 55%, and for females, it's 36 to 48%. Platelet count, the normal range is 150,000 to 400,000. White blood cells, normal range is 5,000 to 10,000. The way I remember the normal range of white blood cells is because think about kids. They usually get really sick. They love to bring home illnesses, viruses, bacteria when they're little, when they're starting school from about 5 to 10 years old. So you can remember the white blood cell count, normal range is 5,000 to 10,000. Electrolyte labs. So these are very important because our electrolytes need to be within normal ranges, especially when we're going under to have surgery. So sodium is usually 135 to 145. Here it says 136 to 144. If it's a number off, I wouldn't be too concerned, but just think 135 to 145. Potassium is usually 3.5 to 5 milliequivalents per liter. And then that's for the whole blood. And then for serum, the range is 3.7 to 5.1 milliequivalents per liter. Magnesium is 1.4 to 1.9 milliequivalents per liter serum, and 3.3 to 5.34 milliequivalents per liter in the red blood cells. Calcium, 2.16 to 2.6. Now we learned about sodium, potassium, magnesium, and calcium, I think in lecture 2 or 3. So we know what they do, and we're going to get much deeper into this in the medical surgical lectures. Phosphate is 0.87 to 1.55. Chloride is 97 to 105. And bicarb is 22 to 30. Like I said, I don't promote memorizing in nursing school except for lab values because they should always be in the forefront of your mind when taking care of patients, when evaluating the electrolytes when they come back from the lab, and to know what a low or high lab value indicates. Nutrition and the patient going to surgery. You as the nurse have to ask yourself, does the patient need to be NPO? And has the patient been NPO? You don't want to come in on your shift in the morning, your patient's going to surgery at 8 a.m. and they were not NPO throughout the night. This is a great way to infuriate the OR staff because the surgery might need to be postponed. So does the patient need to be NPO? And was the patient NPO? If you have a diabetic patient and the patient is NPO, you need to assess their glucose reading. We don't really want to give insulin to a patient who's been NPO and who probably won't eat for at least the next 6 or 8 hours because we might bottom them out. However, if you check the glucose and it's 400, then you would probably want to give them coverage, but this is something I would ask the surgeon on what they want to give and how they want it to be given. But you always need to check the glucose reading on a diabetic patient. Teaching before the surgery. Patients need to know what to expect when they come out of surgery. What will they come out of surgery with? Should they expect to have any drains coming out of their body? They need to know how to use the incentive spirometer. They need to know how to use the patient-controlled analgesic machine, the PCA. How much pain can they be expected to be in? Are there any special positions the patient needs to be in after a type of surgery? And when should the patient follow up? Make sure there are no surprises to the patient. This is going to ease the recovery for the patient. So this is why we try to teach before the surgery on what's going to happen and what they need to expect to happen once they come out of surgery and come back to the floor. Pre-op nursing diagnoses. Very common ones: anxiety related to the surgical experience, the anesthetic part or the pain part, and the outcome of the surgery. So you need to assess your patient. If they have concerns or they're nervous or they have anxiety, you need to talk to them, understand what their anxiety is being caused by, and then provide education. If it's about pain, you can reiterate the patient will be getting pain medications. We're going to try to get them up and walking as much as possible. We're going to pre-medicate before that so they don't have pain while doing that, because we need to get them up. The next one is risk for ineffective therapeutic management regimen related to deficient knowledge of pre-operative procedures and protocols and post-operative expectations. Again, it's your job as the nurse to educate the patient leading up to the surgery, what's going to happen, when it's going to happen, how long the typical surgery lasts, and how you're going to care for them once they come back to the floor. Fear related to perceived threat of surgical procedure and separation from support system. Again, another great teaching moment to let the patient know that their family members can wait up in their hospital room. So when they come right back up to the room, they'll be surrounded by their support system. Deficient knowledge related to the surgical process. So if your patient has any questions or concerns about the surgery itself, that is not your responsibility to educate the patient about. That is the surgeon's responsibility, but you do need to let the surgeon know that the patient has more questions for him or her, and they need to come up and speak with the patient. What are your responsibilities and interventions you're going to do for the patient pre-op? You're going to provide psychosocial support. So again, you're going to be a good listener, you're going to be empathetic, and you're going to provide and educate the patient with things to help alleviate their concerns. During preliminary contacts, give the patient opportunities to ask questions and to become acquainted with those who might be providing care during and after the surgery. The surgeon should come up to the hospital floor and meet with the patient, and usually the anesthesiologist calls the night before just to reiterate the protocols of being NPO, or maybe they're allowed to have a sip of water, but the anesthesiologist most likely will call them. You need to acknowledge the patient concerns and worries about impending surgery by listening and communicating therapeutically. You're going to explore any fears with the patient and arrange for the assistance of other healthcare professionals if required. Again, this is usually the surgeon, making sure that you give a warm handoff to the nurses in the OR so the patient can meet the nurse who's going to be taking care of him or her downstairs. And you're going to teach cognitive strategies that may be useful for relieving tension, overcoming anxiety, and achieving relaxation. So this can be education about guided imagery, distraction, or optimistic affirmations. Some more RN interventions pre-operatively. So you need to ensure and provide that nutritional support as ordered to correct any nutrient deficiency before surgery, to provide enough protein for tissue repair, has been ordered and has been completed. You are going to educate the patient that oral intake of food or water should be withheld 8 to 10 hours before the operation. This is most common. But like I said in the previous slide, some physicians allow clear fluids up to 3 to 4 hours before surgery. But you need to get an order from the doctor. Usually the patients are NPO 8 to 10 hours before surgery to decrease the risk of aspiration. You can inform the patient that a light meal may be permitted on the preceding evening when surgery is scheduled in the morning, or provide a soft breakfast only if prescribed when surgery is scheduled to take place after noon and does not involve any part of the GI tract. So again, you will have orders for this, and then you can relay the instructions to the patients. In dehydrated patients, especially in the older patients, we encourage fluids by mouth as ordered before surgery and administer fluids IV as ordered. We're going to monitor the patient with a history of chronic alcoholism for malnutrition and other systemic problems that increase the risk, as well as for alcohol withdrawal, such as DTs. So this is why it's really important you assess the patient's alcohol use, because you don't want to be under anesthesia and then start having DTs, because that could be a very catastrophic situation. Some more nursing interventions pre-op. Now, of course, the patient isn't going to be in the hospital 2 months before surgery, but we want to urge the patient, if you're working with patients in a doctor's office or in an outpatient setting, we need to urge the patient to stop smoking 2 months before the surgery, or at least 24 hours before. We're going to teach the patient breathing exercises and how to use the incentive spirometer. We're going to assess any underlying respiratory disease, such as asthma, COPD, and current threats to pulmonary status. Assess patients' use of medications that may affect post-op recovery. And in patients with cardiovascular disease, we want to avoid sudden changes of position, prolonged immobilization. Are the patients hypotensive or hypoxic? And making sure not to overload the circulatory system with fluids or blood. So remember, operation, we're thinking keep the patient breathing and keep the heart pumping. So anything that can interfere with that, you need to let the surgeon know ASAP. Some more nursing interventions for pre-op. If the patient has a disorder of the liver in any way, you need to carefully assess the liver function tests and the acid-base status. For those who have diabetes, we're going to be frequently monitoring their blood glucose levels before, during, and after surgery. And of course, the use of steroid medication. We need to make sure that the surgeon and anesthesiologist is aware of the use of any steroid medications for any purpose by the patient during the preceding year, so that we cannot have any complications associated with that. Remember the acronym, can I do anesthesia? So steroid medications, the corticosteroids, the C is the steroid medications we're talking about here. Some more nursing interventions pre-op. As you can see, there is a ton that we as nurses have to do. We need to assess patients with uncontrolled thyroid disorders for a history of thyrotoxicosis, with hyperthyroid disorders, or respiratory failure with hypothyroid disorders. We need to explain the rationale to our patients for frequent position changes after surgery. We want to improve circulation. We want to prevent venous stasis. And remember, our goal is to promote optimal respiratory function. Surgery. We want optimal respiratory function, and we want the patient's heart to keep beating. We want to demonstrate how to turn from side to side and assume the lateral position without causing pain, without pulling out IV lines or drainage tubes or any other apparatus. You're going to discuss any special position the patient will need to be in after surgery, such as adduction or elevation of an extremity, and the importance of maintaining as much mobility as possible despite restrictions. We want to keep that blood flowing through the body. You can teach patients about exercises of the extremities, including extension and flexion of the knee and hip joints. Think of it like riding a bicycle while laying on your side. You can teach them foot rotation, tracing the largest possible circle with the great toe, and range of motion with the elbow and shoulder. Remember, our goal is to keep the circulation pumping and to help them not have any pressure injuries, because we've learned about that. Those are not good to have even a stage 1. And we're going to use proper body mechanics and instruct the patient to do the same. So while the patient is in bed, you need to make sure to maintain the patient's body in proper alignment. And when the patient is placed in any position, it doesn't matter what position the patient is placed in, you need to ensure that there are proper body mechanics that maintain the patient's body in proper alignment, so you don't injure any nerves or muscles. And some more RN interventions pre-operatively. So we're going to teach each patient as an individual with consideration for any unique concerns or learning needs. We're going to begin teaching as soon as possible, starting in the physician's office and continuing during the pre-admission visit when diagnostic tests are being performed through the arrival in the operating room. That would be for an outpatient surgery. The patient comes in for the day, has his or her surgery, and then goes home. But if the patient is on a hospital unit, then as soon as they enter that hospital room, you as a nurse need to start teaching and educating. Remember, we don't want any surprises for our patients when they wake up from anesthesia. We want to space our instruction over a period of time to allow the patient to assimilate information and to ask questions. So as I said in previous slides, we don't go in and teach them everything that you need to teach them in 10 minutes and then say, yes, I've taught them. You need to come into the room multiple times throughout the day, because the patient can then have time to think about what you're saying, and it might take him or her some time to think of more questions. We're going to combine teaching sessions with various preparation procedures to allow for an easy flow of information. We are going to include descriptions of the procedures and the explanations of the sensations that the patient will or may experience. Again, no surprises. Usually with a major surgery, you're going to have pain. We're going to try to alleviate as much pain as we can, but until your body completely heals, you're going to have pain. So you need to let the patient know this so they can expect it, so they don't get more stressed or more anxious thinking that something is wrong. During the pre-admission visit, arrange for the patient to meet and ask questions of the anesthesiologist. They can watch movies about it. You can give them written materials, and also provide them a telephone number for the patient to call if they have questions that arise closer to the date of surgery, so that the surgeon can get back to the patient. Reinforce information about the possible need for a ventilator and the presence of drainage tubes or other types of equipment to help the patient adjust during post-op. So if you know they're going to come out with a drainage tube, let the patient know. I'm sure the surgeon has told them, but maybe the patient forgot that piece of information. No surprises when they wake up. And then, of course, you want to inform the patient when family and friends will be able to visit and that a spiritual advisor will be available if desired. More pre-op nursing interventions. I told you there's a lot. So if the patient's coming in for the same day surgery or an ambulatory surgical procedure, you need to teach about discharge and follow-up home care. Education again can be provided by a video, over the phone, during a group meeting, maybe some night classes, or pre-admission testing, or the pre-operative interview. So they do have group meetings and they have classes on different types of surgical procedures and what to expect when they wake up and how fast it will take for them to heal. Answer their questions and describe what to expect. Again, no surprises. If the patient is coming in for outpatient surgery, you need to make sure that you tell the patient when and where to report, what to bring, such as their insurance card, list of medications they're currently taking, and any allergies. Tell them what to leave at home. We don't like to have jewelry and watches under our care because if they go missing, that just causes a ton of extra work for everybody. So leave at home your jewelry, watches, your medications, your contact lenses, and what to wear. We usually tell patients to wear something comfortable, something loose fitting, and flat shoes. And during the last preoperative phone call, remind the patient not to eat or drink as directed. They can brush their teeth, but usually no fluid should be swallowed. So we always have to push that NPO, NPO, NPO as many times as we can so the patients don't forget. All right, more nursing interventions pre-op. So remember operating. Keep their heart beating and keep them breathing. So we're going to teach the patient how to promote optimal lung expansion and consequently blood oxygenation after anesthesia by assuming a sitting position, taking deep and slow breaths, maximal sustained inspiration, and exhaling slowly. We want to get those lungs expanding and contracting and expanding and contracting. You can demonstrate to the patient how they can splint the incision with like a pillow. This will minimize pressure and control pain while the patient is recovering. And this is usually for thoracic or abdominal incisions. We're going to tell the patient that medications are available to relieve pain and that they should be taken regularly for pain relief to enable effective deep breathing and coughing exercises. So we want to keep them pain-free or have as little pain as possible so that they can do these exercises to get their lungs working really well again and expanding and contracting and having that gas exchange occur. More nursing interventions for pre-op. So we're all about educating. Our goal, our role as a pre-op nurse is to educate, educate, educate. So patients have all the information given at least a couple days before the surgery so that they can mentally prepare. We're going to instruct patients to take medications as frequently as prescribed during the initial post-op period for pain relief. Let them know they will receive pain medication. You can talk about the use of oral analgesics with the patient before surgery and assess the patient's interest and willingness to participate in pain relief methods. You're going to instruct the patient in the use of pain rating scales to promote post-operative pain management. So we're always trying to get objective numbers so that we can initially assess the patient, give them pain medication, come back an hour later, reassess the pain, and hopefully the number has decreased. So this day and age, we are very concerned about patients getting infections because they can lead to more traumatic events down the road. So most patients are instructed to use detergent germicide for several days at home if the surgery is not an emergency surgery. So they'll be given some wipes to wipe their body down to cleanse that skin really good. So when they go in for the procedure, there's a decreased risk of getting an infection. If hair is to be removed, remove it immediately before the operation using electric clippers. So the patient should not shave him or herself. Let them know that the nurse will do it right before the operation. You're going to dress the patient in a hospital gown that is left untied and open in the back. You're going to cover the patient's hair completely with a disposable paper cap. And if patient's hair is long, it may be braided, hairpinned, and then removed after. Again, last thing you're always going to want to do is inspect the patient's mouth, remove dentures or plates so that that doesn't cause a risk for aspiration. So if patient has objects, securely fasten like a ring with tape on the patient's finger so that it doesn't fall off and get lost. We're going to give all articles of value, including dentures and prosthetic devices, to family members, or if needed, label article clearly with the patient's name and store in a safe place according to the policy of the agency. You're going to assist those to void immediately before going into the operating room, and you're going to administer any pre-anesthetic medication as ordered and keep the patient in bed with the side rails up because we don't want them to fall out of bed because you just gave them pre-anesthetic medications and cause injury or fracture. And you're going to observe the patient for any unexpected reaction to the medications, and you're going to keep the immediate surroundings quiet to promote relaxation for the patient. If the patient is going down to surgery because he or she has been in a hospital room, what you want to do is send the complete chart with the patient to the OR. You need to attach the surgical consent form and all of the laboratory reports and the nurse's records, noting any unusual last-minute observations that may have a bearing on anesthesia or the surgery at the front of the chart in a prominent place so that the surgical team can easily access it and read it. You're going to take the patient to the preoperative holding area and keep the area quiet, avoiding unpleasant sounds or conversation. The patient is probably nervous, anxious, and probably wants a quiet environment just to gather his or her thoughts. Here's the checklist I put together for you just to kind of have in the back of your mind, or you can print this out, just to make sure you've done everything that is required by you for the patient. You are going to identify any allergies. You're going to make sure that the informed consent is signed by the physician and the patient. You're going to make sure the patient does not have any further questions for the surgeon or the anesthesiologist. You're going to make sure that all pre-ordered labs are complete and they look good. You are going to have your complete head-to-toe assessment done, and there should be no concerns there. If there are, again, you need to communicate that to the team. The NPO status was started and abided by. All pre-operative medications have been given if they were ordered. The glucose level was checked. There are no medication concerns. Remember, can I do anesthesia? The jewelry is off, and the surgical site is marked, checked, and easy to see. In the operating room, they have what is called a timeout. So the patient is in the room on the bed, And everyone is going to stop what they're doing. They're going to verify the patient against the patient's chart. They're going to verify the birthday that they match. They're going to verify any allergies. They're going to verify any questions from the patient. And they are all going to be on the same page on where they are doing the surgery. And that usually they will mark the spot during the timeout. It's not bad if you pre-mark it for them, but they're going to double check. And this is because, unfortunately, patients have gone in for a left leg amputation and have come out with a right leg amputation. So this timeout procedure was started probably about 10 years ago, where it's just a final checklist, making sure you have the right patient, you're doing the right surgery, and you know where you are doing the surgery on the body. So again, I'm not a proponent of memorizing, but if you memorize this and lab values, expected lab values, then you'll be pretty much, uh, you'll be able to understand what the surgery type it is that is occurring. So I'm going to let you look through this list so that you know any surgery ending in ectomy means a surgical removal, such as a tonsillectomy. An ostomy is the formation of an opening, so a colostomy or a tracheostomy. Otomy means cutting of a body part, but that structure is not removed from the body, such as a laparotomy or a craniotomy. So you really need to understand the endings of these surgical words and know what they mean so that you can understand what's going to happen during that surgery. Here are more surgery types. Just make sure you get used to knowing what the ending of the surgery means so you'll know exactly what's going to happen to the patient during surgery. And it's always good to have one or two examples, like rhinoplasty. Oplasty is a surgical repair. And I think most people know what rhinoplasty is, but find a term that you are familiar with these endings, and it will really help you understand further what type of procedure is going to be completed on the patient. Here are a few more surgery types that you have to memorize the ending or have, like I said in the previous slide, an example of what you already know what's going to happen, and then any other procedure with that ending, they're going to do the same thing, but maybe to a different body part. So endoscopy, scopy, examination with a lighted instrument, lysis, process of loosening, freeing, or destroying. So if you have adhesions, they can go in and loosen those adhesions or free the adhesions from whatever wall they are attached to, or just destroying the adhesions. So again, I hate to say it, but memorize these so that you know what's going on.